afternoon, everyone. Welcome. We'll get started in about a minute, just giving everyone a chance to get into the room here, and then we'll go ahead and kick this off.
So have all three of you just been stuck home like me, or do you get out much? You don't get out?
Stuck home.
Are you? How do you like your house? You must be crazy about it by now. You know, I haven't, because I had the lobectomy in December. So between that and not going back to work for a while, I've been in Albany maybe 10 times in 9-10 months. Pretty amazing.
So are you doing your work, Harvey, with Albany virtually?
Yeah. They're doing
the way. DC has moved to virtual also.
We're either doing phones or Zoom. If they have bad news to tell us, they want to do it on the phone. They don't want to use Zoom. Yesterday they told us about budget cuts, but no Zoom. So.
Well, Daniela, we're live, right?
We are. I was just going to say, Harvey, we've got a bunch of folks in the room, so if you want to get started, we can go ahead and do that, okay?
Sure. You want to do housekeeping?
Absolutely. So welcome, everybody. This is the Federal Policy and National Advocacy Update webinar section of the conference. So welcome, everyone. Just a quick couple of housekeeping things. Today's webinar or today's workshop is being recorded. And you can find the recording and are there PowerPoints for this one? Before I say and the PowerPoint? I don't think so, right?
No,
So you'll find the recording posted at the NYAPRS website at www.nyaprs.org. We are providing CEs for social workers, CPRPs, LMHCs, CRCCs, and certified peers through the New York State Peer Certification Board. In order to qualify for CEs, we've got to have you in the virtual room and not on the telephone. And you'll have to complete the evaluation that's being sent to you within 48 hours and return that to us in 48 hours. Please just keep your cameras off and your phones muted, although we're in the webinar platform right now, so that shouldn't be an issue, but just in case you happen to pop up on the screen, please just come off. And closed captioning is available. To enable closed captioning, we ask you to hover your mouse over the closed captioning icon at the bottom of your screen and use the arrow on the right-hand side to select Show Subtitles. Hopefully we'll have a really lively conversation. Certainly our panelists will keep this thing going. And we do have quite a chat box for you to use. So we ask for you to type in your questions or your comments and type them into all panelists so that we can see them. And with that, I'm going to come off camera and turn it over to you all.
Thank you, Daniela. So first, this is Harvey Rosenthal, CEO of NYAPRS. And I really just want to thank my three friends here for coming on. They are the three smartest people, as far as I'm concerned, in Washington. And hopefully they'll tell us all their secrets today as well, because they probably know maybe more than they're going to say, but I hope they tell us. And I thank you, all three of you, for coming on. We're so lucky to have you. You really are. You know, if I want to know something, I'll call one of you each time. So we did a little emailing, and I did a little reading of your material, and I think we just, in broad brush, what I picked up was you all share a concern about inequities and health disparities, and you also share some concerns. At least I know that Ron and Chuck and I share concern. I'm sure you do too, Jennifer, about the COVID monies and is it going to get to the states? And there's a lot. Well, you're all really talking about racism and, and poverty and social determinants and things like that. So I guess maybe just to start, let me start with Chuck and just ask you, yesterday I was joking before, but yesterday we were on the New York State providers who are getting local aid. The state passes money through the localities. It's not Medicaid. It's 100% state money. And it's been the most flexible, and it pays for a lot of the recovery services and the including case management also, and peers and families in crisis and things like that. So as you may know, Chuck, you probably know from your other members like me there, that we've been on a 20% withhold. The governor's kind of played it a little cute. He hasn't cut us, but he's pulled the money back with the idea that he's thinking he's going to get it back and give it back to us. Those are a lot of assumptions, that he gets it back and that he gives it to us. So I guess, but the first place to start is the long, endless holdup between the White House and the Senate and the Democrats. And it seems like the issue of money to the states is the deal breaker so far. Can you say what you're hearing or what you think or what we ought to do?
Well, Harvey, first of all, let me just say thank you for letting me be with you today. And I would just disagree with you on one thing. I think you three are the smartest people I know. So, I shouldn't be here. It's hard to know, Harvey, exactly what is if there is any one particular issue that is holding up congressional action on another COVID package, or it's much more kind of, I think, of an existential kind of exercise, right? About do states need additional resources? You've probably seen some of the coverage from the Wall Street Journal that has been picked up by the Republican Ways and Means Committee, that monies that have gone to the states have not been spent.
Right.
And therefore it's hard to believe that, kind of the argument that folks are engaging in is why do we need to pass on more support? I think what that argument fails to recognize is the reason states aren't spending all of the money they've received is because, and they've been very clear about this, they've not gotten sufficient guidance from the federal government about the parameters associated with those dollars' use, and therefore they are concerned about kind of any potential paybacks.
Mm-hmm.
The Medicaid, the National Association of State Medicaid Directors have made it very clear that with the kind of the economic downturn that is occurring, the kind of growth that we're seeing in the Medicaid program, without additional federal support, either in terms of additional FMAP or federal Medicaid support or other support to states, that there will likely be cuts. It's always amazing to me, that for the last 4 years, the federal deficit hasn't been an issue, but magically, all of a sudden, it's an issue. I wish I had a crystal ball and could tell you one way or the other that Congress will be moving on a large piece of legislation, but at this point, I have absolutely no idea.
Chuck, where do you see the elections playing in all this? I mean, is it going to, we have to wait till after the election before we see anything, or?
I don't know, Harvey. I think there are some other issues that potentially could come into play here in terms of, what does the polling look like? I would have thought just the opposite. I would have thought that we would have seen a bill in order to help some of the vulnerable Senate Republicans, but I think they must have a calculus that that's not, that's not gonna matter. I think the upcoming election will be really important on a number of levels in terms of healthcare policy, into the future. And that might be what we need in order to see action on another COVID bill.
How could they, how would the Republicans run if their fire department services or schools or mental health services are it's going to be like an election issue, isn't it? That New York, there's possibility they'll cut money to the schools. Not really, because they sued to avoid that. But I guess I'm just wondering, why would you run at a time when by inaction, you've cut basic services for people? Why would you not try to fix that? Or am I being naive? Or
I'll turn to my other panelists to see what
okay.
if anybody else wants to try to take a crack at that. I think it's all, it's all a political calculus, right? Do they have more to lose or to gain one way or the other? And
Okay.
obviously they feel like they're okay with inaction. It's not going to hurt them politically, but I see Ron nodding. Is that?
Yes. So I agree with Chuck, and I think part of the issue here is the feeling in the Senate and by Mitch McConnell and others that by putting this money out there, they will be helping Democrats. They'll be helping blue states more than they'll be helping red states, and that is not in their advantage prior to the election. So I think that has cooled the whole thing down tremendously. Plus, I think there's two sides here. One side, the Democrats in the House came with a $3 trillion bill. The Senate came with the $1 trillion bill, and this is what's now called the skinny bill, and so on. I think they partly couldn't reach agreement on the magnitude of the money. I think there's a question out there, do you really need $3 trillion? Democrats wanted to compromise on $2 trillion, say, we'll come down $1 trillion if you come up $1 trillion. They had no deal. So everybody walked away from the table. I want to say about 8 to 10 days ago. So I think I agree with Chuck. And I think kind of the bottom line of this, nothing is going to happen on this till after the election. And how the election turns out, I think, will play a huge role in what does happen once the election is over.
Isn't it true, though, that the president kind of broke into this, supposedly surprised the Republicans by wanting to put up another $200 billion? So, and some people would say so he can send out, send out stimulus checks, not to help the states. Is that what you're hearing or saw? That's what I thought I was getting that from the papers.
Yes, and he also, in some of his executive orders, has been trying to overrule regulation and so on to basically put more help out there to common people, basically.
I would just say, I think that, we're in something of a different cycle than we have been in many past elections, where I think the messaging just looks different, right? With the really the way that online news works now, the way that people get their news, I think it is easier for people for members of Congress to worry less about some of the things that would have been, I think, more concerning before, but now I think there's a lot of entrenched news sources that people turn to, and it really is, it has changed the calculus, I think, of how people think about things. But the other thing is that also, I mean, whatever was true a week ago, I think now with the death of Justice Ginsburg, that the Senate has a lot of things suddenly going on that really also changes the entire picture of what's likely to happen and not, I think.
How does it do that?
Well, all of a sudden, you have senators spending a lot of time and energy, I think, on the Supreme Court and what is going to happen. And this is going to be the battle of a lifetime, I think. I mean, some people would tell you, well, the votes are already in, and some people would tell you that's not actually true. But, certainly this would shift the balance of the court in a way that I think would have very, very dramatic impact on people's lives in many respects. And you have the Affordable Care Act case, which, it's already set for argument, but what the Fifth Circuit had done was basically try to send it back to the judge, to the trial court judge. And so, even if there were a 4-4 decision and, that would let the circuit's decision stand, then it goes back to the trial court judge to figure out really the scope of, what this all means, basically on this severability question of, okay, if the individual mandate's not constitutional, then what happens to the rest of the law? And that's going to go back up again. And so, the stakes are enormous, absolutely enormous here. And so I think that is what is going to take up a lot of the oxygen in the Senate right now. And I think it's going to make it that much harder for people to come to agreement. And plus, I think there's going to be a lot of, obviously, partisan divisiveness over that, which is not going to help on COVID.
When, I mean, do any of you think, that so-called threat by Biden, I think it was, that all things are on the table if they bring in, like another justice? Is that an empty threat? What does that mean? If the Democrats take over Congress, they'll block all kinds of things Republicans want, and does that matter? Anybody?
I think, a couple of pieces of that I've been hearing about. So Nancy Pelosi is threatening impeachment proceedings again. I don't know if she's directing them toward the potential candidates that would be running for the Supreme Court position or whatever. And then I think secondly, the Democrats have also talked about adding people to the court. So if you get 5-4 or 6-3 that you don't like, you can add more people, because there's nothing in the Constitution that says it has to be 9 people. And there's actually nothing much in the Constitution that says about, other than, the people need to be confirmed by the Senate, of how this gets done. Franklin Roosevelt tried to increase the Supreme Court, I think, to 15 people. And it didn't go well for him when he tried to do that. So I guess if they asked me, I would say that's kind of a long shot. And, and if you're going to play that long shot, you got to then play it all the way through. And you may not be successful, basically. So I think when they say we pulled out all the stops on what we're doing, that those are the kinds of things that I think they are talking about and threatening. But I don't know what level of reality to attribute to any of it yet.
Mm-hmm. So Jennifer, I was reading your piece where you say, I think you're taking legal action around weakening of, some connection between weakening of the ACA and protections for people with disabilities. Do I have that right?
I'm not sure. We have taken some legal actions on certain things. I'm not sure what thing you've seen. We have one thing that it might have been is an amicus brief that we and many other folks had filed in the Supreme Court in that Affordable Care Act case, which really kind of lays out just how important the Affordable Care Act is for people with disabilities, mental health disabilities, as well as all other types of disabilities, and all of the different ways, really, that it has so changed the lives of people with disabilities, both in terms of expanding, insurance coverage and expanding the types of services that are covered, with the Medicaid expansion, which has been enormously important, particularly for people with psychiatric disabilities, and all manner of things, and these new home and community service options, and many other pieces, pre-existing conditions, provisions, protections, and so many other things. And so that may have been one of the things that you have seen. I know that we were involved a little bit in there have been challenges in the courts to some of what has happened with some of the rules, like the junk insurance rule, which made it much easier for insurance companies to have these quote unquote junk insurance plans that don't meet the Affordable Care Act's requirements. They don't have essential health benefits, which, for example, require that mental health benefits and substance use disorder benefits are covered to some extent. They don't have most of any of the protections of the Affordable Care Act. And the administration, HHS, did a rule that basically really put on steroids how much you can have those kind of junk insurance plans available and how long they can be available. And so that was challenged, and they have a hostile judge. We had filed a brief in that case, along with a lot of other disability groups, kind of highlighting again sort of the importance of the ACA and the reason not to have those junk insurance plans and how they harm people with disabilities, with mental health disabilities, with cancer, with epilepsy, with multiple sclerosis, et cetera. And so that may have been something that you've seen that's now up on appeal. There have been other things who knows what else, but lots of things happening with the Affordable Care Act and you know, in both the courts, you know, the effort, and I think it was sort of unprecedented in this administration to have the Justice Department turn around really and do a 180 and say we're not only not going to defend the law anymore, but we're going to sort of take the position that it's unconstitutional and that the entire thing has to fall. And so, you know, you have that, but then you have all of these efforts to do kind of death by 1,000 cuts with all these different agency rules that are really trying to cut away at both Medicaid and the Affordable Care Act's protections in so many different ways.
So Ron, I'm convinced that you wrote the ACA because you have you put so much energy into it, and you've kept us all informed about it for so long, especially when it's in jeopardy. What's your view of this, about the future of the ACA?
Well, I'm hoping that, I'll give you my hope here. My hope is that reasonable heads will prevail in the Supreme Court. I believe that the Chief Justice, you know, is a reasonable person. I think he's a moral person. I think he recognizes the consequences. And I think, you know, it's not exactly clear, if it were the 8 people, exactly what the outcome would be currently. Now, if you add another person to that, that may change the calculus completely on the ACA, I guess is how I would view that. At 4-4, he may vote with 4, you know, as part of the 4 and keep it, as opposed to, you know, knock it down. So I think you just have to watch how this plays over the next few weeks and so on. They are going to listen to testimony on that case. I believe it's on the 10th of November. So the election is the 3rd. A week later, they're going to listen to testimony. And then they will be doing analysis and so on. And I assume it will be several months before they issue a determination. It probably will be spring or late winter before they get a determination on this. And I just don't know the ifs and buts. If the person is not in seat 9 at the time they take testimony, I don't know whether that person then votes on the case or doesn't vote on the case. If it were me and I wasn't there when they took testimony, I guess I would say I need to recuse myself because I wasn't really part of the arguments here.
Yeah,
I didn't ask any questions and so on. I don't know what the legalese of that is.
If there's a new justice at the time of consideration, but that person wasn't sitting at the time of the argument, then that person doesn't participate.
Okay, so then what I'm saying still potentially could be true, even if the 9th person is appointed but not seated on the 10th of November, basically. So I think you just have to watch this play. It's like a kind of a psychodrama playing out here over time that we all watch. We all watch every day, but it isn't just for humor. You know, there are millions of people's lives at stake. And even with the ACA, I was reading some numbers this morning, even with the ACA, with some of the things that have been done in the last several years, we have gone from a little more than 5% uninsured to more than 9% uninsured, even with the ACA right now. And you know that behavioral health always runs behind that. The uninsurance rate in the behavioral health group is always about double what it is in other groups. Therefore, I don't have the data right in front of me, but could go and do an analysis. I would predict that the uninsurance rate among people with mental illness right now is probably somewhere around 18 to 20%.
Now, isn't that, Chuck, a breach of parity? I know you're big on parity. I mean, is that allowable to have that many people not covered?
Yeah, you know, parity only applies if you have health insurance, right? It doesn't address at all a kind of underlying whether or not you have health insurance. And you know, I think, you know, what's troubling is probably what's keeping even more people from falling into that category of uninsured is the Medicaid expansion. And so we've already talked about two things that have huge implications here, right? One is the lack of further federal support for states and or Medicaid could lead to cuts and or, right, if the Affordable Care Act is struck down, what happens to the Medicaid expansion that was part of that? So these are very worrisome issues.
So this is worse than watching CNN. I'm going to go back and watch that. And I hate CNN right now. So what about COVID? Where it's on everybody's mind here in New York. I testified last week, and Jennifer, I read your stuff pretty much on the issue of congregate care and that states. This brings up the issue: why are so many people in jails, prisons, group homes, state hospitals, and things like that? Wasn't that your point to some degree?
Right. Well, we did a couple of things. One on decarcerating people with mental illnesses, from jails and prisons. There have been a lot of decarceration efforts. It seems like people with mental illnesses have not so much been included in a lot of those efforts, or far fewer have moved out. But then, in addition to that, we really have been focused on also trying to do something about all the deaths in congregate facilities. And obviously there were already underlying concerns, civil rights concerns about this is not sort of the most integrated setting appropriate. It's not a good setting in many cases for people. And trying to get people in, trying to get community services expanded, which the lack of sufficient community services really being the reason that a lot of people have been stuck or presenting in the first place, at hospital or another facility, or stuck in a boarding care home for forever. And so now on top of that, you have layered on that suddenly it's not a safe setting anymore, health-wise. And when you think about social distancing, and you've got CDC guidelines talking about the importance of social distancing, no comment on CDC now kind of going back and forth on things, but certainly from the beginning, I think that has been a very clear tenet, the importance of distancing. And in these facilities, you've got people with beds that are less than 6 feet apart who are living in rooms together. You've got people, going into dining halls where, they're waiting online shoulder to shoulder, and they're, at tables, and they're, I think there are things that have been done. Certainly, after some of the litigation, there has not been nearly the kind of litigation that there has been with prisons and jails. Which is interesting. I think for the most part, it's been something of an overlooked issue, or an issue that people have talked about but not really done anything about, to try to, get people out, do sort of emergency, discharging and planning for kind of how we're going to reduce the census in these places, whether it's in psych hospitals or whether it's in boarding care homes. And I think we have a lot more information certainly about the state-run places, state hospitals. It's, I think, a big question mark what's happening in a lot of the boarding care homes. I know that it was hard for us, even in our own case, to get information for a while. Well, in several cases that we've
Your case in the New York City adult homes, you mean?
In the adult homes case, in our case in Illinois, some of the other cases have been state-operated facilities. It's been a little easier, but in New York, I know that at some point the state said 4% of the class was now dead, and it's it's hard to
Hard to hear that.
there's your clients are just dying, and it's hard to get things to happen to stop that. In Illinois, I think the numbers were also pretty significant in terms of deaths of people in the nursing homes, and a little bit less so in the places where we have clients in these IMDs or specialized mental health rehabilitation facilities, but a significant number, I think, overall. And so, we have been trying to do things to get people out. And of course, ironically, you've got this pretty dangerous situation, but at the same time,
No, no.
because of how COVID has impacted the community service system, that has really sort of brought to a halt the transition process that people were engaged in. And so people aren't getting out, except in dribs and drabs. And that's been, very frustrating. And, some of it was stuff that needed to happen through telehealth. And so certainly we've seen, over time, that has gotten better and the restrictions have been lifted. And, now it has been a matter of like actually implementing, in all sorts of ways. I'm sure Chuck knows better than I do, sort of all the ins and outs of kind of, how that has happened and, what some of the barriers have been. I know that we've seen plenty of things like, a bunch of people in institutional settings, like somebody brings in a box of phones or something, and then, they're not getting to people, or they get to people, but, they're not actually able to use them, or there's not reliable internet
Or
service.
the minutes are not there. But,
Kinds
yeah.
of things. And so, meanwhile, people are stuck, and there's also issues around the, being able to come in, just to have community providers come in to do. Some of the things need to happen face to face with all the telehealth that's happening. Some things just, require the providers to go in and to help people with aspects of the transition process. And, CMS guidance had sort of suggested that that couldn't happen unless, I think there were some ambiguities about who was essential or not. But, now CMS has a new guidance out that seems to say that, other health providers should be able to go in now. But, I think there are a lot of things that remain unclear. And certainly, I think we remain in a situation in most states where people aren't really transitioning out in great numbers. Certainly nothing like what was happening before. And so that is, I think, a significant concern. And one of the responses was, federal legislation to really incentivize a great expansion of home and community-based services. And that was, something that was in the HEROES Act. And, I think specifically to try to help ensure that more people can transition out of these institutional settings and be diverted from them. But, one of the things that I'm not sure people realized was in the HEROES Act, the way that that provision was written didn't cover most community mental health services. And I don't think it was intentional in talking to sort of the health staff that were involved, but we were hoping that on the Senate side, should that go anywhere, that could get fixed, and that would certainly help. But I think even with those, community services, there's just a lot of things that seem to need to happen before we're at the point where we can really ensure that, like, the number of people that can be transitioned to the community, to ensure that the census is such that it's safe in the facilities and that people can, be safe and get some, reasonable services in the community. We don't seem to be there in a lot of places.
So I'm going to ask only a couple more because I know people out there want to ask you. So Chuck, just on telehealth, I know you're very focused on that. What is the National Council wanting there? An extension of the current latitude, or?
Well, I think what we've heard from our members is we certainly would like to see some extension of current telehealth flexibility. And I think, I liken, kind of what we've seen, we've all experienced in terms of telehealth, kind of comparable to what the future of work is going to be like. Like, I can't imagine that any workplace is going to look exactly the same way it did whenever we return to something being normal, right? I think many of us have grown accustomed to working from our living room in our shorts and don't want to have to wear suits again every day. And I think the same is true when it comes to telehealth, that we'd like to continue to have some flexibility to engage people using telehealth technology, remote patient monitoring, other kind of digital supports. I think the concern would be, how do we make sure that that is structured in such a way that it actually works for people, that it's a choice, not something that's forced on people, that it's being done in a way that helps facilitate ongoing kind of growth and recovery. And so I think those are areas that we're going to be trying to engage in, is what do those models look like? And then how do we also make sure that funding reimbursement continues to be sufficient for organizations? So those are some of the things that are on our mind. You know, obviously it looks like CMS is interested in continuing this as well. In the physician fee schedule rule that they released a few weeks ago, they're indicating that they want to preserve some of the flexibilities, telehealth flexibilities in the Medicare program. I would imagine if states would come forward seeking similar flexibilities in Medicaid, I would imagine that those will be approved.
So how many people think Ron is wearing shorts and flip-flops?
Every day, every day.
Never. So Ron, you wrote a lot. You wrote a very powerful piece, I thought, and talked a lot about disparities. You want to talk more? I mean, both in terms of racial and any number of areas. So would you talk more about that? It was a very strong piece.
So just a little bit of context. So I think, you know, in the areas we deal in here, we're dealing with several types of disparities. One is the disparity in health status of people who have mental illnesses. Another one is a disparity in access to care. And I guess I'd even go so far to say there's a disparity in the operation of the behavioral health system relative to the health system. So it's kind of a multi-tiered type process. So you have to unpack it and say, what are you trying to work on? So what I was speaking to in the piece that you're referring to is the first level of this. What about disparities in the health status of people? And the second piece, and also in access to care. I wasn't doing a systemic analysis. Mm-hmm. And it's very clear, and we've known this, that it's nothing new. We've known this for 50, 60 years. You know, the lower your social status, the more likely you are to become mentally ill. And who has lower social status? We know that minorities are overrepresented dramatically among people of lower social status and so on. And the rates of mental illness in those groups can be 8 times what they are in the highest social groups. And that data has been around for 50, 60 years. So the issue is, when you have a disparity that's due to a social discrepancy, then you need to address that in some equitable way. You need to introduce equity into that situation. So I think there's a lot of work ongoing in behavioral health right now to think of how we can introduce better equity on health status of people, and we can introduce better equity into access of care. Now, a particular piece of that right now is, what are we doing about racial inequities, racism, structural racism, and so on? And I think that the work that the field has done in the last several years on social and physical determinants of health is a very important piece of that. However, on racial disparities, I think you need to go even a step farther back and say, what is it about communities that lead to the social determinants of health that you're actually witnessing in that community? Why are things the way they are? Why are certain of those people not having access to housing? Why don't they have jobs? Why are they overrepresented among people with disabilities? If you get into that and you start working that, then you work back to, in effect, dynamics of power in communities. And there are really 3 dimensions of power. There's a status dimension of power, there's an economic dimension of power, and a political dimension of power. And I think there's some initial work now going on in the field, which I think is very promising in this respect, to go in and look at some of those dynamics and ask the question, how can a community actually come together? How can I bring together the business people in a community with the public sector in the community, with the not-for-profits in the community, and say, my God, we have to do something about these power dynamics because they are leading to these particular problems for big segments of our population here. So I think some of that work is very promising. I'm very active in a project called the Grand Challenges for Social Work. We just added, previously we had 12 grand challenges: 4 in health, 4 in well-being, 4 in equity. And they're national challenge. You put that all together, you'd have a very good agenda for the domestic policy of the United States working on those 12 things. Very recently, we added a 13th agenda, and that is to eradicate racism. And I guess in that work, we come to the conclusion a major part of eradicating racism is working on structural racism in the way that I was just describing it. So I think that work shows a lot of promise. And I think in the field, we are going to have to embrace racism as an issue for us. And it can't be simply business as usual going forward. We actually have to step forward and make some changes in what we're doing and how we're approaching some of these problems. So I think some of this promising work will be worthwhile looking at, as we go forward. So what I was trying to basically force with that writing is to say, part of the agenda of 2021 is to look into these issues and make some strategic steps to begin addressing this as a field, basically.
I had a real insight, this painful, infuriating, really insight. This whole, all the racism that's in our faces really has caused me to look much more at class and, and poverty and things like that. So last week, the school systems, which were supposed to take a cut like we are, sued the governor, and he backed off the cuts. And here we are getting cut because the people in state aid, it's really just me, are poor, maybe people of color. They don't vote. They don't have money for lawyers. They don't vote. It's just outrageous. But to me, it just felt like, there's an example where the school, most of the people that are, the school systems that are behind this lawsuit are not the ones in the poor neighborhoods. I'm sure it's more white middle class and above. And here we are, our poor people, often black people who rely on state aid. They're being cut. I just
exactly. So, but those are the kinds of things we have to grapple with and take on, and actually must become part of the agenda. Must become part of the agenda in 2021 once we have a new president.
Thank you, Ron. You must know something I wish for sure I knew. You always have the inside dope, so I'm going to go with you on that one. So back to racism and police. In Rochester a couple of weeks ago, Daniel Prude was killed by a police officer, 6 police officers, all of them white, I believe. Certainly the one that killed him was a white officer. It's complicated as far as I can tell, because it looked like, even though he's being portrayed as mentally ill, it seems like it was a PCP overdose, and that it really required a medical, not necessarily a behavioral health intervention, because he was just melting down and was at risk for cardiac arrest. So what we're saying here in New York is this is the police, once and for all. We have advocates here for crisis intervention teams for years, and they have now said, we can't use, it's not a training solution. It's not about training the police. It's about replacing them and sending someone else and getting 911 to call someone else when somebody calls 911. So here in New York, we're saying you should call a trained peer counselor with a EMT. So the EMT would have diagnosed, in this case, the PCP, and might have seen, had medical action taken more quickly. Maybe the peer could have, de-escalated. I don't know when you're on PCP to that degree whether you can be de-escalated that easily. But what's your thoughts anyway about policing? I'm sort of babbling on here about police reform and first responders. What
Well,
you know? Yeah.
well, let me make you take it in a slightly different direction first, and then
Sure.
see what the other folks want to say.
Sure.
So there's been some activity in the chat room around 988, and so there's efforts at the federal level to create 988 as a national line for people who are having a mental health or substance use crisis. And I really see that we have an opportunity to make that as an alternative to 911. And so I think that is that's the opportunity that we have before us to start planning. It's going to take about 2 years for 988 to come into being. And I think, this is the work that we'll need to do, advocates and providers with state authorities, to really figure out how to structure this. So not only do we have the infrastructure to answer the phone calls, but also then to make sure that we have adequate crisis response, peer teams, and rapid access to other mental health supports for folks who need it. So I'm gonna take maybe a longer view, and maybe Jennifer, others have other thoughts on the topic.
So this is Danielle. I just want to cut in real quick. We had lots of questions in the chat box. If people could just explain, or if someone could just explain what legislation 988 is, because we had lots of questions in the chat box about that. People were unsure about what we were talking about. Yeah, so 988 is basically, right now we have a national suicide hotline. It's a 7 or 10-digit number, and the idea here is that we would have a 3-digit number for people who are either suicidal or, much more broadly, having a mental health or a substance use crisis. That you would have a 3-digit number called 988 that you could call. The FCC has already indicated their support for the creation of this number, and yesterday legislation was passed that would then help pave the way for there actually being resources to implement it. So that's what happened yesterday.
So Chuck, say a word more about the legislation. I thought that it was introduced, not passed.
No, it passed by unanimous consent yesterday in the House.
In the House, okay, and we still need to take this to the Senate.
No, it's already passed the
Okay.
Senate, so it's on its way to the President.
Okay, and likely will be signed.
Yes.
Okay.
No reason to believe it wouldn't be.
Yeah, excellent. Very important.
Chuck, I was reading that was one of your agenda, was to get it passed in the House. Were you surprised that it? I mean, I read yours today, and now it's passed. So,
I think we would have been more surprised, Harvey, if it didn't pass, right? Like, it had passed the Senate. Why wouldn't the House take it up? I think it is a good idea, right? Now it's a good idea. We just have to make sure it actually gets implemented correctly, so that it actually can be a credible alternative to 911. That there are appropriate mechanisms in place to support people.
And I think that's actually, really, I think the big question, right, is how to create the infrastructure, the Chuck reference, whether, it's for a 988 response, or whether, you're talking about in the interim, or even after there's 988, all the calls that continue to come into 911. I think there are now a few of these models across the country that have gotten attention. Everybody has been talking about the one in Oregon, and now there's one in Denver and some other places, or in some places it's kind of, that's happening, but it's less talked about and less formalized. But I think that is a real significant opportunity for us too, to really ensure that there can be a different response. I mean, part of it is a mental health response, part of it is often something else, but something other than a police response to so many of the situations where people are calling the police or 911. And, you know, people end up dead, people end up incarcerated, people end up with all kinds of bad outcomes that really, you know, could have been averted. And, you know, there's really very little that the police could do that sort of help. And I mean, I agree with, I think it was Ron that talked about sort of, it's not so much a training issue at this point. I mean, yes, you know, sure, trained police are better than not trained police, but we really have to kind of look beyond just training. And I think that, you know, the more that CIT has been studied, the more questionable it is, you know, that it
Really?
helps a lot of time. And I think some folks had talked about that in the chat box, and yes, but you know, what is what is that infrastructure going to look like, you know, with the coordination between sort of the 911 and the police and some, you know, central control or in the mental health system somewhere, and you know, who comes out and under what circumstances does somebody come out, when do you have somebody come out alone and not with a police officer, when is there co-response? I know there was sort of lots of interest in co-response for a long time, and frankly I think we, you know, have been trying to explore, well, you know, let's get beyond co-response and get to the, you know,
Yeah.
where should there not be
Yes.
a police officer responding, you know, where can we avoid that, frankly, because you know, when you have you know, a co-responder situation, it's still, it is not the same thing. You know, having a police officer on the scene often really changes the whole dynamic. And so, you know, where we can avoid that, where it is not necessary, we should.
Yeah.
I do think you're going to see, I mean, there are already some bills. I mean, Senator Wyden has a bill that really is not totally connected. I think it's connected more in title maybe than it is in substance to kind of the, you know, CAHOOTS Oregon model, but it is kind of a, you know, enhanced Medicaid match for a mobile crisis with this in mind. And then Katie Porter is working on some legislation on the House side, which is a federal grant program for 911 and police triage to, you know, direct mental health response in inappropriate circumstances, and to have some reporting and studying of that. And I think all of those things are good and helpful. And I would hope that, you know, while there's still this debate over these policing bills, that, you know, some of this will find its way into a larger police reform bill.
Are you, Jennifer, in favor of a peer and an EMT instead of a clinician and an EMT? I know that's a debate in the recovery community, or in the, you know, the more radical community, that the CAHOOTS model, which sends out a clinician, is inferior to sending a peer and an EMT. Do you have a?
Yeah, I mean, I guess it really depends on the situation, but it does seem that, you know, certainly I think peers are incredibly important and probably the most important intervention
Yes.
in so many of these circumstances, if not most.
Okay. So, Daniela, I'm going to turn it over to you. Are you here?
I'm here.
Okay. If you want to, if you're keeping track of
Go through
questions,
some more questions. Yep,
we've got
sure.
about,
We
we've got about 15 minutes to go.
Yep. So we had a bunch of questions around COVID. People are asking if there were any numbers released regarding COVID deaths in psychiatric hospitals, also for residents of mental health housing facilities, and then what measures, if any, are in place, I guess, on the federal level to help psychiatric residents and respite residents to stay safe during the age of COVID.
So in terms of psychiatric hospitals, I mean, I think there's a patchwork of data. I don't know that there's anything where anybody's sort of tracking it across the country. You know, the last letter that we wrote about this was in August, and I think cited articles from a number of states. You know, we do know certainly that it's somewhere around 40% of the people who've died nationally are in some kind of congregate care facility, whether resident or staff, nursing homes, assisted living facilities, psychiatric hospitals, intellectual disabilities institutions, and homes and stuff. But yeah, I'm not sure that there's kind of a clear national number. I think you just have, you know, some state data, and mine is actually probably a month old, so not very accurate at this point. But
So I think an important comment to interject here is the fact that we need to be advocating that the federal government do a much better job of collecting data on mortality in all care settings, not just psychiatric hospitals, but in all care settings. So we actually have current data on what's happening. I did a lot of work on mortality data in the past, and the mortality data in behavioral health is actually terribly shocking. So I would expect if we actually knew the data here, it would probably be shocking to us.
And it is very frustrating that I think in, all of the COVID relief bills that did pass, there were data collection provisions. And for the most part, I think the really important ones tended to exclude people with disabilities. There was a lot of data collection provisions asking for collection of demographic data. And it would, talk about race and gender and other stratifications, but disability, my understanding is that it kept getting taken out. I'm not sure, exactly what that was about, but we all kept advocating for it to be in there because obviously it's hard to, here we are always in the situation where I say, well, I've got this article and I've got that article and now this article, is a month old. And meanwhile, the federal government's not collecting it. I got a letter from Dr. Redfield at the CDC in August after having written them in, March, or actually I think April, asking, for them on the administrative level to collect data on, look at even, like CMS could look at, samples of Medicaid claims or something and, figure out what was happening with people in different settings. And, not everything would show up in terms of COVID testing and COVID deaths, but I think there would be enough that, you could get a picture. And certainly it would be very meaningful for driving policy, for driving solutions if we
Absolutely.
had that. We keep failing. I mean, it's like people keep asking over and over and over again for disability to be in those data collections, and we're not getting very far.
I just want to say that, to be clear on what I said earlier, I just wrote a letter yesterday to the Rochester paper saying there should be a peer and an EMT, and we should lead with that. I guess I'm just reflecting, there is this other model. I'm not saying, I think we should really try peers, but I also have to say I'm just worried about over leveraging peers in some situations. Not that a clinician would be perhaps more effective with some of these cases, but anyway, the position is very strongly to do a peer and an EMT. I just wanted to, I think there is some controversy around it, however. Okay, Daniela, you have something?
I do. So actually on the heels of what you just said, lots of folks are chatting in the chat box and typing in, what goes on in their different areas. Some folks have CIT teams with social workers, some with mental health counselors. So they're asking sort of what should the composition of the teams be? I guess to ask your professional opinions on that one, although we've started to hear a little bit about that.
So let me start off here. So I've had students at USC address that issue. And one of the things that they come up with in the work, their projects, is that if you're putting someone into a team, it should be someone who has what they call social work sensitivity. It should be a person who not only understands the environment, but they understand what are the various things that might be available to help this person even beyond behavioral health care services. So I'm not saying it has to be a formal social worker, but it has to be a person who has some social work sensitivities and who has some knowledge of what's available in the community. What kind of housing is available? What kind of social supports are available? How does a person get access to SSI? All those kinds of things that are relevant in many of these cases. And I think failures of those systems are the cause of a lot of the crises we have, basically, currently.
I see a point by actually one of our board members, Jeremy, and Jeremy saying that there are many peers and social workers who worry if they're utilized in crisis response, they'll be expected to steer people towards psychiatric emergency rooms and contribute to over-hospitalization. And while it's better than being shot, we have to be careful not to trade one institution, jails, for another one, hospitals.
So let me comment on that also.
Sure.
So we're working hard in the field, and I hope Chuck and Jennifer will comment as well, to move toward a crisis response system that is community-based, not one that shifts people into jails or shifts people into emergency rooms or shifts people into a psychiatric hospital. And we're working hard to build that. And I just want to give credit to the state mental health program directors. And I believe Chuck was the speaker there. I think they devoted their entire meeting this fall to the development of state crisis response systems. So all of these questions that are being raised here are on the agenda currently of the states, and they're also on the county agenda. I do a lot of work in this space on crisis response. For example, we're trying to build a regional crisis response system in Kansas right now to address problems in rural areas. You can't have a crisis response system for every little rural county, but you can probably put together a regional one. And then how do you build on that? The virtuality you need to have in COVID, who should be staffing this? All those questions are up to bat right now. And it's a good time to be putting your dibs in. I think peers absolutely have to be playing a role here. And I think we need to find out more about the role peers can play in this. Harvey knows, and I've said many times, I think the whole behavioral health system should be run by peers. And so if we had more peers running this, we could do more, basically.
Ron, could you just, or any one of you, say, what does the alternative, so to Jeremy's point, so you have someone who's distressed, you don't send the police, you have an EMT and a peer, say it's not a medical issue. Now you just have the peer. The peer is able to de-escalate, but the person needs to settle down or maybe sleep, need emergency housing or whatever. What is the alternative to what we all want? Not an emergency room, not a hospital. You're talking about regional centers or whatever. What do they look like? What are they?
Well, some that I've actually visited in LA, they have what I would call instant response emergency centers for crisis response. So someone will come in, and LA is still on the model where they send out police with someone else. So the police and the co-responder will bring the person in. The facility is set up so that it can address whatever that person needs. So if the person needs to come in and sleep, there's a capacity to do that. If the person needs to come in and take a shower, there's a capacity to do that. If the person needs to come in and talk to someone, there's a capacity to do that, et cetera, et cetera. If the person also has, a knife wound or a gunshot wound or whatever, there's capacity to address physical health issues as well. So the approach there is to try to meet the person wherever they are, to address their needs on a short-term basis, get them stabilized, and then link them to more long-term community-based services. So I think the model is right. And they're even experimenting in LA County of replacing the police on these efforts with EMS people, which I think actually would actually be very good. And so I think the model is evolving, and now is the time to do work on it. And, as I said before, find out how the role that peers can actually play in this.
A peer-run agency in the Hudson Valley, Steve Michio's people, is taking over the Crisis Stabilization Center in Poughkeepsie, to your point, and it will be a drop-off site with all those,
exactly.
medical, mental health, addiction, and
yeah, exactly.
It's not like this is sort of so new, right? I mean, we have living room models, we have peer crisis respites, parachute type places. I mean, we have, a lot of there's crisis apartments. I mean, it's not that common, but I think, that is something we've advocated for. And, some states have that paired with mobile crisis teams so that there's, a place that, people can go for a temporary period. But I do think that, one of the concerns I have is people focus so much on the response, kind of what Ron's saying, so much on the response, or like before that, what we saw is drop-off centers. Everyone loved drop-off centers, and we're going to take everybody to a place. And, it's good because we're not taking them to the hospital, we're taking them to someplace else. But, all of that is only so useful if you don't have the services to connect people to. And so I think, we've been
Yes.
trying to be
Yeah.
careful about sort of ensuring that infrastructure gets built, or none of this is going to be all that helpful.
Well, I think that's a really important point, Jennifer. We don't need another place where people can get lost, right?
Yeah,
We don't
yeah.
need to create another system that is disconnected from ongoing care and support. And I think and Ron, all this activity is happening right around crisis systems because we're kind of thinking about the implementation of 988 and making sure that this is done in a holistic way is going to be really important.
Yes, absolutely. Agree completely.
Any questions, Daniela? We have 5 minutes.
Yep, we can move on. When we were talking about telehealth, there was a comment about access to technology for telehealth has really impacted this individual's program participants' ability to participate in telehealth. So maybe we want to talk a little bit about access in different areas and how we could perhaps work towards improving access.
So I guess the first quick comment on this, one of the things we learned as soon as we went into COVID on March 15th is that the absolute importance of people having telephones, and telephones that actually had minutes on them, that an important vehicle for a lot of the people we deal with wasn't sophisticated technology. It was actually having a telephone that someone could call them on and they could call someone else on. And so we put a lot of effort into advocacy for telephones for people because we recognize most people did not have the technology they needed to actually participate into virtual care. And I think that's a very important step. And part of what Chuck was talking about earlier, preserving telehealth benefits, we need to consider not only paying for the telehealth meeting, but also paying and helping to pay for the telehealth technology that makes it possible for the populations we deal with in behavioral health to actually participate here.
Another question?
Just looking at the chat box, and
Yeah, me too.
made a response to someone named Victoria Kelly, I think, who talked about being on a crisis team, being a peer and kind of being marginalized. And this is something I think that, I've heard again and again. And I mean, I think one way to deal with this, and this is certainly, something people have written a lot about, is to really have something that is clearer in CMS guidance about, at least to the extent that this is Medicaid financed peer support, or peer roles on a crisis team, or in any other context, frankly, that really could help address this widespread problem and make clear that peer support workers have a very important role to play, and they're not just there as like cheerleaders, or as people to do menial tasks, or to be dismissed, but something that really clarifies, I think, sort of the role is like as an equal. Basically, it's a different role, but that people shouldn't be treated as somewhere like down on the totem pole or something, or it really destroys the integrity of the service and its effectiveness. So I mean, I people have not really focused on that. I know, Harvey, I was talking to you a little bit about that recently, and what we could do maybe with CMS in a different administration to try to push that issue, because it's such a huge problem.
Very much.
Yeah, and there were actually tons of comments in the chat box around that, about peers and peers being recognized for their expertise on teams and having a full seat at the table.
You know, that might be a good topic for a NYAPRS webinar follow-up from this conference, to bring some people together to talk about, maybe find some emerging good practice where a peer is really has the right role and is valued and is, you know, there's some data and something like that.
Yeah.
Well, our time is out, and I know the commissioner, I don't know if you noticed, but the commissioner of mental health is listening to make sure I didn't say anything wrong. So thank God.
Harvey never says anything wrong here.
Harvey, I'm so glad we've had this time together. Thank you.
Yeah.
Thank you.
Thank you very much,
Appreciate it.
Harvey.
Really
Great,
appreciate
great.
it.
Appreciate
Great
all you
conversation.
do, Harvey. We
Thank you.
appreciate you.
And all of you. Thank you so much.
Take care.
So I think I stay on and the rest of you leave is what I think happens.
Yep, we're going to swap over.
Goodbye, Jen. Goodbye, Ron.